Let's jump straight into it. We got the news about following the live stream. And of course, ideally, we followed it because we've been curious about this. But the technology scored 81% on the exam of its first try. Talk to us about that bit, particularly knowing that maybe we don't quite understand the algorithms that go into it or the kind of set that was given or registered to the tech. Help us understand what we were working with that gives so much disparity with actual doctors.
Thank you. Let me take you through the test. What happened exactly? There is a lot of apps out there doing symptom check.
Right.
What has been happening is those are not usually reliable. Those have not been checked against the gold standard of healthcare, which is the doctors themselves.
Right.
So our assumption was artificial intelligence would perform better than those. So we needed to check it against the gold standards, which are doctors. And eventually, and this is what happens in practice,
Right.
doctors need to sit for an exam. So we needed our AI to sit with the exam that doctors normally sit for,
Right.
and see what happens. So we developed what we call vignettes. Vignettes are clinical cases. They are scenario that normally happens in, let's say, for instance, you have an adult, 30 years old, male, suffering from headache. What would be your diagnosis? What would be your management? What would be the advice given to him? So we take 100 cases like those. We check them against GPs coming from the Yale University, from Stanford, from the Royal College of Physicians. And then the same cases, we check them against our artificial intelligence.
Right.
That was the first test.
Right. And the data set, so how much of that comes from Africa?
A few come from Africa. Obviously, our artificial intelligence has been developed in a particular context, which is the UK context.
Right.
What we are now doing here in Rwanda is we are actually testing it in our context and customizing it.
Right.
To give you a few examples, in the UK context, it's possible to advise a patient to call an ambulance because his condition is just too serious.
Right.
But in our context, for a patient to get access to an ambulance, probably he would go to a health center, and from there they will pick him. So these are things we are putting into our AI so that it can make sense in our context.
Right. All right. So ideally, despite the promises of the new system, there are limits, right, to AI. And we've noted this before. At an infrastructure level, the savings capabilities of AI are perfect. But just to be clear, this does not replace the doctor, because obviously there will be a lot of questions on what happens to the jobs that were there before.
Sure. The fear factor has been so big here. People see sometimes the AI as a competitor.
Right.
This is not the way we see it. For us, AI is just a tool. This is a tool to empower doctors. This is a tool to sometimes change the paradigm of power from the doctor to the patient side. So a patient can make decisions for himself.
Right.
But for us, we are seeing artificial intelligence as just a tool. So sometimes they say, well, it cannot do as good as doctors because it cannot perform a physical examination. This becomes an issue when you consider it as a replacement, a possible replacement for doctors. We do not see that as a challenge because it's just a tool in the hand of doctors. We will still need the doctor on the background checking.
Right. Okay. So we've spoken to at least some of the different practitioners, and they say, of course, there's a global shortage of doctors. But then we also had a panel here in Rwanda some time back, and during Transform Africa, I think, and one of the representatives from JICA, vice president, said we have very many doctors, right? But we need less doctors and more specific practitioners. So coming now from the artificial side of things, which is which?
Let us look at numbers here in Rwanda. In Rwanda, we have one doctor for about 12 to 14,000 of population. The WHO states that for you to be called a normal state, you should have at least one for 6,000 to 7,000.
Right.
We are quite above that number.
Right.
On the other hand, when you look at the number of doctors coming out of university, here in Rwanda, the University of Rwanda, you have about, generally about 100 doctors coming out of the university. And on the other side, look at the way the population has been increasing. Although the government is doing a lot, and here I must praise the government of Rwanda, they're building a lot of hospitals, a lot of health centers, health posts, helping graduate more doctors. But when you look at natality, you start feeling anxious.
Right.
When are you going to be able to bridge that gap?
Right.
That's where artificial intelligence comes in.
Right.
This is just a tool to allow the few doctors that are there to reach the many that are also out there.
Right. Let's talk about practicality now, because anytime you want to look at the health sector in different countries, you look at mortality rates, fatality rates, of course, as well. You look at issues like non-communicable diseases, health insurance. So what are the main drivers for, first of all, implementation of this, and what do you think they'll be able to address, or the intelligence will be able to address initially?
Well, artificial intelligence can address just eventually every condition. We already know that artificial intelligence is already helping diagnose some cancer cases.
Right.
This is already undergoing. We know that digital healthcare, what we've been doing as Babyl in Rwanda, as of now, we are addressing every kind of condition. Of course, there are limitations. For instance, in Rwanda, we cannot touch to obstetric,
right, because
there's just so much I can do with a woman in her labor.
Right.
I can just advise and give first aid advice. But our product has been quite liked by a particular number of patients, notably chronic patients, right, patient living with diabetes, patient living with cardiovascular diseases like hypertension, right, patient having epilepsy. Those are patients that normally would go a lot to health facilities. It is expensive for them, it is expensive for the health system. And sometimes they just go there for a check, just for prescription refill. These are things you do not need to go to a health facility for. These are things we can help with.
Right.
Again, there are, I would say, conditions that require some kind of privacy, some kind of intimacy, like sexually transmitted diseases, like rashes on intimate parts. Those are people like...
A lot more personal.
A lot more personal.
And that's where the doctor comes in as well, also for the physical bit of things. Let's just talk about the future of this. We saw you coming in 2014. Of course, we downloaded the app ourselves and we tested it here at the studio. So is it a rollout in phases, or what's happening? Because we know there has been progress on AI in Rwanda. What's the next step and where are we currently?
Definitely. Here in Rwanda, we are in the process of testing AI in our call center. This is the first step. But eventually, can you imagine the power of this technology in the hand of a health center nurse, helping her with her triage, helping her with her diagnosis? Right. This is tremendous. It is actually groundbreaking. Now, imagine this in the hands of every individual out there. A patient checking his symptoms before he even thinks about going to the hospital, to the health center. Right. That is the end goal. But to get there, we need to check it with our call center, we need to test it, to approve it, then we put it in the hand of some health practitioner out there in the health centers, and then eventually just in the hand of every Rwandan.
And what's the toughest bit trying to accomplish all this?
We're already testing it in our call center and we feel like we are nearly there. I would say early next year, but of course, when we come to that time, we'll inform you.
You'll understand what the issues are as well. Possibly as we leave just a bit, you're a medical practitioner yourself. Is it a bit, what is it? Is it comforting or surprising that now when we talk about Babyl, we talk about it as a tech startup to watch? Wall Street Journal said it was one of the best tech startups to watch. This wasn't there when you were studying medicine, right, back in the day. So how are you wrapping your mind around all this?
True. Well, that's an interesting question. Yes, I'm a medical doctor, and of course my first aim is care of my patient. But at the same time, I would say I have the best of both worlds.
Right.
I'm doing what I like, giving access to health care to my patient, but I also have that goes with working for a private company, which is efficiency.
Right.
It doesn't happen everywhere, but sometimes when you're working for big institutions, state institutions, things tend to be bureaucratic, tend to be... But when you're working for a private company, you have that efficiency that goes with it. You are accountable.
Right.